Good morning, and thank you so much for joining us for today's webinar, Steps to Effective Intervention Design and Adaptation. I am Dafina Ward, Interim Executive Director of the Southern AIDS Coalition, and we are really thrilled to have this opportunity to speak with you all and share with you all in a more in-depth around our funding opportunity through the Transformative funding opportunity. So many of you likely participated in webinars last week. The webinars were overviews of the funding opportunity across the 3 coordinating centers. And while I will touch very lightly on the general request for proposals and instructions, I would encourage you, if you did not participate in the prior webinar, to access that. It will be on the Gilead Compass site and available for your viewing throughout the application process. So that's where you'll find more in-depth information regarding the funding opportunity and instructions and about all 3 of the coordinating centers as well. So today's webinar will be more specifically around Southern AIDS Coalition's funding opportunity, and we look forward to sharing this with you all. Today's presenters will be myself, and I will provide an overview of SAC's funding opportunity through Transformative and give you a bit of insight regarding internalized stigma as it relates to intervention design. And then following that, we will have Dr. Jagadisa Dacus, who will share with you more fundamental information and content regarding the development and adaptation of interventions. Our agenda for today, I've welcomed you, welcome. And if you'd like to jump in the chat and say good morning and tell us where you're from, we would love that as well. We're glad to have you all here. As far as instructions, I believe everyone should be muted at this point. Please remain muted throughout the webinar just so we can keep noise at a minimum, so everyone can hear. We will hold questions until the end of the webinar. So we hope to have an opportunity to address each of those questions. I'll facilitate that Q&A at the end, and so we'll have an opportunity as well once we finish with the questions in the chat box. If folks need to voice questions, we'll provide a space for that as well. So we'll have, and I'll provide an overview of this funding opportunity through the Gilead Compass Initiative, an overview of stigma. Then Dr. Dacus will dive into intervention design with you all and provide some takeaways, and then we'll have a Q&A session to close us out. And again, this webinar will also be made available on the Gilead Compass website for those who are unable to attend, or if you should need to go back and spend some additional time with this presentation, you will have an opportunity to do so. Additionally, we will make available slides from a prior webinar that Dr. Dacus conducted around intervention design specifically, as today's presentation will delve into adaptation in addition to design, but we will get into intervention development and the nuts and bolts in that. In a separate webinar, you will have access to those slides in the coming days. So to get us started, I just want to do a quick overview of the Transformative Grant funding opportunity. The Transformative Grant funding opportunity is an opportunity for funding of up to $100,000, focused on supporting the development and implementation of programs and activities across 3 areas. Emory University is funding organizational capacity building, supporting organizational capacity building activities, including but not limited to infrastructure development, coalition and network building in your communities. And Emory will also be doing a separate webinar around their funding opportunity this week. So please check the website for that information. Secondly, the University of Houston Sustained Compass Coordinating Center is funding work around well-being, mental health, substance use, and trauma-informed care, with a focus on the development, implementation, and evaluation of new or even existing interventions around wellness, mental health, substance use, harm reduction, and telehealth. And lastly, we're all here today to learn more about SAC's funding opportunity, HIV-related stigma reduction, with a focus on supporting the design, implementation, and evaluation of community-informed interventions with the purpose of reducing HIV-related stigma. The eligibility requirements, we are funding work in the 9 Deep South states: Alabama, Florida, Georgia, Louisiana, Mississippi, the Carolinas, Tennessee, and Texas. All those applying to qualify, you must have a 501c3 or a fiscal sponsor that you've entered into agreement with. The grant period will run from January to December of 2020. All those selected will need to complete an organizational survey and other data collection tools as a part of being a part of the Transformative Grantee Partner Cohort, and agree to working with the evaluation partner from the coordinating center that funds your work, as well as the Compass Initiative Evaluator, ETR. And for the purpose of our work at Southern AIDS Coalition, you'd be working with Duke University for evaluation around your project. The Southern AIDS Coalition is funding intervention design and development, as well as implementation. The first area of funding opportunity is for the development or adaptation of an intervention. So that may be the formal development of a community-based program that you all have been doing in your community, which you would like to mold and shape into an actual intervention for implementation and evaluation purposes. It could also mean the adaptation of an existing evidence-based intervention to add modules, activities, and key components related to the reduction of internalized HIV-related stigma. Secondly, for organizations that have already previously developed and piloted an intervention, you may apply for funding for implementation and evaluation of that intervention over the 12-month grant period. So we hear the word stigma a lot, and we often don't see a definition for it. And we know that it can look and feel many different ways in our communities. So we thought we would just share this definition and provide some insight to get us grounded in this conversation. And we recognize that the impact of stigma in our communities can look different across our organizations and across the communities that we're serving, and also recognize that there's not a one-size-fits-all manner for addressing stigma in our communities. A number of studies have been conducted around the impact of stigma, and these types of HIV-related stigma are consistently related to negative health outcomes. We recognize through the work that's happened in the South that there are a number of opportunities to address internalized stigma in the people that we're serving in the region. We know that those who are dealing with and facing stigma in service delivery and community settings and social settings in their personal lives, that can impact adherence, sexual risk, medical care use, social service utilization, as well as their physical and mental health. So the Southern HIV/AIDS Strategy Initiative conducted a stigma study across 4 Deep South states in 2 ways. Through surveys of 201 individuals living with HIV, mostly recruited from HIV care clinics, some from AIDS service organizations and other CBOs, and as well as 6 focus groups of individuals at what's perceived as higher risk for HIV, primarily MSM of color, others in communities of color as well, and those who may be utilizing substances or women who are in care for substance use. We wanted to share with you some of the findings from a SAC study because we thought that very much informs the way that interventions should be developed and designed to service the needs of those who are dealing with isolation and dealing with the other repercussions of internalized HIV-related stigma. Those who participated in the study reported the following. In the 3 months leading up to their involvement in the study, more than 25% had been insulted because of their HIV status. Nearly a quarter of them had been blamed for their HIV status. And more than 20% were told they had no future because of their HIV status. And 31% said that at any point in time, they had been told not to share food or utensils with family because of HIV. This slide also shows some of the findings from the survey questions regarding the perceptions of stigma. These have been combined the number that said strongly agree with the group that said agree. So you can just see how strongly these are reflected in the stigma scale. And the stigma scale is something that those who are funded by SAC would work very closely with Duke University around in determining the best way to utilize this scale in the work that you're doing in the community through your intervention. In addition to the perceived HIV stigma, we really have to address the power of HIV stigma that's internalized. So here we can see where participants agreed or strongly agreed with statements of feeling guilty because of having HIV, feeling ashamed because of their HIV status, or feeling that they're not as good as another person simply because of their HIV diagnosis. So there are a number of associations around internalized stigma that we have to be mindful of in the development and design of programs in our communities for persons who are living with HIV. So you can see here that a higher score on the HIV stigma scale for internalized stigma, there was specifically the HIV internalized stigma subscale, was associated with poor self-reported physical health, lower social support, probable depression diagnosis, poor medication adherence, and a number of other issues that could be addressed through an intervention in your community. Our friends at Duke and at SASE did a lot of work, and in looking at the multivariate associations and the way that one thing could influence the other. And so the relationship of internalized stigma with the outcomes of adherence and missed appointment are something that we have to keep in mind, and were found to be statistically significant relationship between the two. We also recognize through our work, and if you go and look at if you look at the RFP and also the overview of the funding opportunity in that webinar, we speak a lot about the values that we hold as coordinating centers in this work. And how that translates to this is that what we see and what we do in relationship to addressing and serving those who are living with HIV in our region is inextricably linked to the other challenges, conditions, barriers, and systems that impact their lives. So we recognize that HIV-related stigma could also be related to race-related stigma, sexual orientation and gender identity, mental health, poverty, and substance use. And that those things must often need to be addressed together to truly have an impact on the lives of folks we're serving. This is just some qualitative information that came out of the study as well. Folks start to feel afraid and terrorized. And that's something that we have to keep in mind as far as what people are walking into the room with, and recognizing that that is a huge piece of whether or not folks will be engaged in our programs, and goes back to our core value around MIPA, the meaningful involvement of persons living with HIV and AIDS in the actual design of our programs. At this time, I'd like to introduce Dr. Jagadisa Dacus. Dr. Dacus is a postdoctoral fellow at the HIV Center for Clinical and Behavioral Studies at New York State Psychiatric Institute and Columbia University. His research focuses on maintained HIV negativity in Black men who have sex with men, and aims to identify and understand the psychological, social, and spiritual strengths and resilience that contribute to the maintenance of HIV negativity in Black MSM populations. Dr. Dacus is a great resource, and we are very excited to have him here as a subject matter expert to share with you all around the effective design, adaptation of interventions. Dr. Dacus. It appears we may be having some technical difficulty. Give us just a moment, and Dr. Dacus will be on.
Okay, can you hear me now? All right, I'm unmuted.
Yes.
Okay, great. Good morning, everyone. My name is Jagadisa Dacus, and I'm really excited about being able to facilitate this portion of the webinar with you this morning. One of the things that I want to include in my self-introduction is that in addition to being a behavioral scientist researcher, I also am an organizational capacity development person. And in relation to what I'll be covering today as a subject matter expert, for about 7 or 8 years, I actually did a lot of organizational development and capacity building that was funded by CDC for organizations that adopted and adapted many of the evidence-based interventions. So a lot of my work had to contend with or dealt with technical assistance and training persons in implementing the evidence-based interventions. Next slide. So as Dafina mentioned, we had a previous webinar where we talked about several steps to intervention development. Okay, so I see that people cannot hear me very well. Give me a second and let me see if I can change that. All right, so hopefully this is better. If you could just let me know in the chat. Okay, great. Okay, so previously, as Dafina mentioned, there was a previous webinar we did where we covered the 8-step process to developing interventions from scratch or building upon previously developed interventions or programs that you have at your organization. So I'm not going to really go into great detail here, but here are a couple of slides here that talk about the steps in the process. So this first slide here are the first 4 steps about reviewing, exploring, developing, and becoming familiar with behavioral science theory. Next slide. And then the other 4 steps have to deal with creating activities related to the intervention, designing evaluation, drafting the intervention, and piloting the intervention. There's actually will include a reference at the end of the presentation that actually relates to the article, the publication that me and my co-author developed around developing this process when working with the community-based organization here in Brooklyn. Next slide. So let's get to the meat of what we'll be talking about this morning during the webinar. So why do we want to adapt evidence-based HIV prevention interventions? Next. So when thinking about adaptation, there are a lot of things that organizations and the adaptation team needs to really consider, like the fidelity of the implementation process, what is the research behind the intervention itself, how will it affect the treatment or the things that the persons in the intervention are supposed to receive, and how do you maintain intervention integrity? So there are lots of things that come to mind when thinking about this adaptation process. Next. So evidence-based interventions, if you could just scroll through them, please. So the Institute of Medicine has recommended the use of evidence-based interventions to prevent new HIV infections and has strongly recommended the use of EBIs, as I'll start calling them now, since the early 2000s. And given the time and cost associated with the development, implementation, and evaluation of HIV interventions, adapting existing interventions for priority populations can facilitate the development of new interventions. So we know that there are interventions that are out there, and as the priority populations with which we work evolve and grow and their needs change, we need to develop interventions to really meet them where they are. So the process of modifying an EBI while maintaining fidelity of its core elements or the internal logic of the intervention is what's described as adaptation. Next. So Gina Wingood and Ralph DiClemente have systematically developed a framework for adapting evidence-based interventions known as ADAPTIVE. It's an 8-phase model for adapting evidence-based interventions. And so this presentation is really built on their model because they have used this model to adapt many of the evidence-based interventions that are out there today. And there's also reference to the article with which this is the work with which this is gleaned from at the end of the presentation. Next. So the adapted model is an 8-phase process, and it consists of assessment, decision-making, adaptation of the intervention, production of a draft of new intervention, engaging subject matter experts or topical experts, as they call them, integration of that new content, training the staff, and then testing the new intervention. Next. So in the first phase, it's about assessment. So this is really doing all of the formative work needed and necessary prior to doing any of the actual concrete work around developing the intervention. So with the input from the priority population, the organization, and the adaptation team, it conducts focus groups because it's important to hear what persons of the priority population believe and feel that they need. Elicit interviews, and this is from key stakeholders such as funders, folks in the community stakeholders, and also organizational stakeholders, and then conduct needs assessments. So this can be using existing needs assessments that the organization has or modifying those ones to really determine what are the needs of the priority population. And I say all this because CDC has specifically stressed the importance of assessment as a key part of the adaptation process. So, considering if an organization is going to adopt an intervention and they feel like they need to adapt it, it's important that they have, enough data and information to support the adaptation process that they're proposing to do. Next. The second phase is the decision phase, and this involves reviewing the pre-existing HIV interventions that are out there that are found in articles and publications, and also in the CDC compendium of evidence-based interventions. So rather than reinventing the wheel, see what's available that's out there. There are a number, close to 60 interventions that are part of the compendium. And I didn't put a link in here, but in the slide deck that Delphina will send out from the previous webinar, there is a link to the compendium there that lists all the evidence-based interventions that are out there. And the ones that have been disseminated widely can be found at effectiveinterventions.org. And so they've been out there for quite a while, so I'm certain that many people have heard of several of the interventions that are out there. But it's important to see what's already there. And then you decide, after you've gone and reviewed what's available out there, which evidence-based intervention you want to select for your priority population. And finally, you decide whether you want to adopt the intervention and just use it as is, because it seems like it is doable and feasible to do so, or whether you feel that, well, yeah, this definitely could work with our priority population, but we need to really modify it so that way it fits them more appropriately. Next slide. So that brings us to the third phase, which is the adaptation process. And so this step involves using what's considered an innovative pre-testing methodology known as theater testing. And theater testing has been commonly used to test products such as TV ads, videos, print ads, and public service announcements. And this is where the organization gathers a sample of the priority population, and they invite them to respond to a demonstration of the intervention. And at the end of the demonstration, the participants receive a questionnaire, and they answer questions designed to gauge their reaction to the demonstration. So this is really getting feedback about whether this will actually be a good fit or not, and whether we need to really adapt some elements of the intervention. Next slide. Then involves the production phase. So this is the first round of producing a draft of the adapted intervention. Now, one thing to keep in mind with this phase, when organizations develop the first draft, this involves balancing the need to maintain fidelity to its core elements, and those are the elements that have been proven effective that make the intervention work with the population. The underlying behavioral theory, so that really undergirds and supports all the activities, the actions, and the sequence of events of the intervention, and the internal logic of the original EBI. So these are all things that really need to be kept in mind. Next slide. So this phase considers, appraises, or evaluates, and you can just scroll through the rest of these, the organization's capacity to modify and implement the adapted evidence-based intervention. So this is really important. So once the production phase starts, the organization's capacity is very important. You can adapt an intervention that could seemingly be fantastic and will be really great, but the organization may not have the capacity to implement it due to resources, staffing constraints, even time, right? Or maybe just some changes in the needs of the priority population. But also it's important to consider and assess what resources are available for key stakeholders. And so if you have a funder like SAC, they're making resources available so that way organizations can fully support the adaptation process and implement interventions with their priority populations. And then also you weigh very heavily on the results from the theater test. And this is where we get feedback from those who were engaged in that process. And they let us know whether it's a yay or nay or maybe, what are some things that we could possibly do that would be able to move this process forward. Next slide. And then you come to the next phase where you bring in the topical experts, or as we more commonly call them, the subject matter experts. And these tend to be or can be persons who are consultants who possess expertise in substantive content areas that are related to the draft that the organization has developed, for which the organization may not have the expertise. In my experience in working with organizations, we were brought in a lot to help them with this process. Around saying, okay, so this is where we want to go. We don't have the capacity to go there, so we need some assistance to do that. And so what's really nice about the CDC's evidence-based interventions is that there's fully funded capacity building systems available. And then also funders like SAC will make those same resources available for you also. Next slide. Then we come to the sixth phase, which is integration. And this involves integrating the content, the materials, all the things that the topical experts have provided the organization to help them adapt the evidence-based intervention. And the integration of the content from these experts results in the development of a second draft of the adapted evidence-based interventions. Next. So integration of intervention content suggested by the topical experts is also weighed by a number of factors, such as, next please, you can scroll down through them. Prioritizing the capacity of the organization to implement the suggested adaptation. So once things have been integrated, the topical experts have weighed in, the organization assesses once again, can we do this? Or how can we do this? And then also, it's about maintaining fidelity to the core elements and the theoretical underpinnings of the original evidence-based intervention. And so these are the things that really make it work. The things that are supposed to ideally stay the same or be as aligned as possible to the original, to how they originally were incorporated into the interventions. That way they can maintain the fidelity. Otherwise, it's believed that the intervention will not be as effective. Next slide. Then we come to the seventh phase. So after you have that, it's about training. So this is training for the persons who will be involved in the adaptation process. It involves training staff in group management and facilitation skills. So like many organizations have folks who run groups and probably could use some support around developing and refining their facilitation skills. If you've had experiences like I have working in organizations, staff often get grandfathered into these roles because they're really good at engaging people, but may not necessarily have a lot of the key skills that are needed to develop, to facilitate an intervention. So you want to make sure that you set the staff up in a way that they can be really successful to deliver the intervention with fidelity. Also, effective recruitment and retention strategies and techniques for those folks who are the recruiters for the intervention. Folks who conduct the assessments, making sure that they have training in how to administer assessments, and for those folks who are going to be managing all the information and the data, some training and support on how to do that. Additionally, you may have a topical expert that may be actively involved in training the facilitators because on the material that they've developed or contributed to the intervention. So that's one of the benefits about having a topical expert or a subject matter expert is that they can really work directly with the organization and with the staff that will be facilitating and implementing the intervention. Next. Then we come to the eighth phase, which is testing. And testing has two parts, two discrete parts. The first part involves pilot testing with approximately 20 participants from the priority population using a third draft of the adaptive intervention. So this is what's been done after the second draft and that transition part. And so I put a little asterisk, oh, go back please. I put a little asterisk here for 20 because this is what has been recommended. So if the organization has the ability to pilot the intervention with 20 people at once, that is really great. However, sometimes organizations have to be kind of creative about how they may pilot. They may have a pilot in two parts with maybe sort of smaller groups so they can kind of compare. You know, it's also, this is, you know, there may be some considerations around how to get participants or that many participants into a pilot. So, I put that there because this number is sort of the ideal. Next slide. Then the second step involves conducting what's called phase 2B process. And so if you remember from the second phase, it's really about like selecting the intervention and figuring out how it was going to be adapted. And this involves basically randomizing the priority population into a group that receives the adapted intervention or participates in that intervention, which was created previously, or a control group that actually is part of, that receives the intervention as is. And this is a way of assessing the short-term efficacy of the adaptive intervention. And this will provide the organization with information about, you know, how does the adapted EBI that they have developed compare to the original EBI that was made available. Next slide. So as you can hopefully tell, there are lots of benefits to using the adaptive model. You know, one of them is that it directly involves members of the priority population, key stakeholders, and organizational staff in all phases. So it really is a very involved process. Also, it helps to triangulate, you know, diverse measures by using numerous types of data and assessment. So from the qualitative approach by conducting formative assessment and process measures to qualitative approaches using the theater test, surveys, pilot study, and pre- and post-test surveys as part of the assessment process. It also uses multiple and novel pre-test methodologies. So focus groups, eliciting interviews from key stakeholders. It's action-oriented through the theater testing approach. Can be computer-based, you know, depending on the intervention, just to test for readability and integration with technology. And also to indicate what needs to be adapted and how adaptation can proceed or should proceed. Next slide. It also attempts to promote a balance between fidelity and adaptation. One of the things that I encountered a lot when I provide technical assistance to organizations is that they like the idea of the intervention, but they wanted to change it very drastically. And what I would encourage them to do is thinking about like, okay, this is what they envision it would be like, but also how can that lend itself to maintaining the fidelity of the intervention? Because keeping in mind that the intervention is considered to, you know, to be the core elements in internal logic are the things that make it work. So the adaptation process really should not be so drastic that it does not align with the internal fidelity and logic of the intervention. It also encourages the use of topical or subject matter experts to assist in creating the adaptive intervention. So the burden is not so heavily on the organization and the staff of the organization to do all the work themselves. They can actually get folks who have those expertise to come in and support them. And this point here, which is one of the things I really like about the model, is that it prescriptively indicates, right? So it really provides a very logical process and steps about when during the adaptation process, a draft of the adapted EBI is generated and the number of drafts that are to be created. So the adapted model prescribes 3 different drafts throughout the whole process. It also facilitates the documentation necessary for efficient adaptation. So developing an adaptation plan and also a way to document what the process was like for evaluation purposes. Next slide. This model also indicates the sources of data that are used for data analysis. So data from the focus groups, the theater test, exit interviews, pilot study, and the phase 2 of the process, which is that randomization of participants into the adapted intervention and those who receive the standard intervention or the control group. It also uses a sequential and systematic process to create an adapted intervention. So there are guidelines to help along the way. So folks have, there's a roadmap, basically. This is where you're starting, this is where you're going, this is where you're going to end up, and what the process can look like. It assesses adaptation efficacy of the adapted intervention via a pilot study. And we know how effective that pilot studies can be in giving us information about what we need to work with, what we're working with, and where we need to go. And it assesses the short-term outcome efficacy of the adapted EBI by means of the phase 2B process. So it's that randomization and control model that's used. Next slide. So here, this is taken from Wingood and DiClemente's piece on the ADAPT model. And what it does is basically, this is everything that we've covered in really great detail. And I really like this table because it really provides a very comprehensive overview of what the process is like. The different phases, the questions that are asked during each phase, the methodology behind each phase and to answer those questions, and the status of the draft development throughout this process. So for example, with the first phase of assessment, the basic question is, who is the new target population and why is it at risk of HIV? Then the question is, what EBI is going to be selected, and is it going to be adopted or adapted? The third is, what in the original EBI needs to be adapted and how should it be adapted? And then during the production phase, the question is, how do you produce draft 1 and document adaptations of the work that you've done with the EBI? When working with the topical experts, you ask the question like, who can you get to help adapt the EBI for your population? And with the integration, what is going to be included in the adapted EBI that is to be piloted? And with training, the basic question is like, who needs to be trained? And finally, with the testing phase, was the adaptation successful and did it enhance short-term outcomes? Next slide. Okay. So I have just a few takeaways from the adapted model that I've presented. The first one is that we understand that cookie cutter approaches to intervention and implementation are less efficacious. As our population's needs evolve and grow, we need to have interventions that really can meet them where they are. So many of the, there are quite a few evidence-based interventions out there that are pretty dated, that really could use an update. And so, this is where the adaptation process can be really, really helpful. Ones that were developed like over a decade ago or more may not be as relevant to the situations or the circumstances of priority populations now. Next. Also that, increasingly more, there is an emphasis placed on how effective interventions need to be culturally congruent and culturally competent. So, understanding that you may have a base that you're working with, but also it's important that it attends to and recognizes the cultural needs, aspects, and important factors of the priority population's lives. Next. And the adapted model offers a prescriptive method of evidence-based intervention adaptation that has been effectively applied to several of the CDC's EBIs. So if you read the article by Wingood and DiClemente, you'll see that the model or the example they use is from the SISTA intervention, which was developed by them to reduce HIV in cisgender heterosexual Black women. And then they adapted that intervention and developed Sealy was one, Willow was another, to work with young women, to work women of childbearing age, and there's different circumstances. So it actually has been proven effective. Next slide. So here are the references. So this is the article I was referencing by Wingood and DiClemente. So it's about their adapted novel. And I'll say that it's actually a pretty straightforward read. I think it is actually pretty accessible. And it really outlines everything in great detail and elaborates upon everything that I presented in this webinar. I can say that I've had the, Gina's here at the center where I am, so I've had the opportunity to really talk to her in great detail about the adapted model, and she's talked about how it has been applied and how she still goes out into the field and is called upon as a topical expert to support organizations that want to adapt many of the evidence-based interventions. The second reference here is related to the previous presentation, and it's really about what Defina talked about before around how to develop and conceptualize behavioral interventions, which is a piece that I co-authored with a colleague of mine. Next slide. All right, so at this point, want to open it up for any questions folks may have.
Thank you, Dr. Dacus. If folks want to add a question in the chat or put an asterisk in the chat to let us know that you'd like to ask a question, maybe unmuted to ask a question, we welcome you to do that at this time. And as we're waiting for folks to formulate their thoughts for questions, I do want to let you know that as the Southern AIDS Coalition decided to provide this opportunity during the application process, because we recognize after our first year of Transformative that a number of organizations were very interested in intervention design and adaptation, but they had not had the opportunity to have any development capacity building around those areas. So a number of you are doing phenomenal programs in your community, and we just hope that we could help provide some insight that would help you as you're formulating the design of your program proposal. And additionally, that it would support you in work plan development and also in your budget structuring as well. Oh, and what is an EBI? An EBI is an evidence-based intervention. And we will provide those slides. The previous presentation we've referenced was a presentation that Dr. Dacus did for our current grantees as a TA opportunity earlier this year, and we will make those slides available. This presentation, yes, will be available as well as the previous slides from the session that was specifically around design. Oh, we do have a question from Pat Kelly. When you speak of the 20 persons needed for pilot, can they be 20 combined in different places, or does it have to be 20 in one place? So I assume, Pat, are you saying can it be 20 total across different sites, or does it need to be 20 in each one? Okay, Dr. Dacus. I'm sorry, Dr. Dacus is muted again. Let's see if we can.
Okay, can you hear me?
Yes.
Okay, great. All right, so let's go to the first question is.
So Pat Kelly was asking. Mm-hmm.
Okay, so this is where I just kind of alluded to the fact that you know, you can get creative, right? So you know, I'll say that it doesn't have to. I think sort of the ideal would be that you would conduct one sole pilot test, right? If you can get that many people. But I could actually see you might have an argument for conducting multiple pilots in different places or locations, right? You know, there can be, but it all depends on like what the adaptation premise is. Maybe you have multiple sites, and you want to do small groups with participants at each site. I mean, that makes a lot of sense, as long as it's you know, related to the core adaptation process of the intervention.
Thank you.
Okay.
Elias, thank you for your question around the availability of one-on-one TA sessions. We may not have the capacity to fulfill one-on-ones for every applicant, but we welcome you if you'd like to send an email to info@southernaidscoalition.org, and we will do our best to accommodate opportunities for one-on-one conversations. So Dr. Dacus, what would be a realistic expectation for intervention adaptation during a one-year funding period?
Wow, that is a really great question.
Yes.
Because I'm sure folks have been thinking this is quite the involved process. You know, when I've worked with organizations that have used the adapted model, Most of them have gotten to within the first year, if they were working very expediently, to the point where they developed the third draft and were prepared to pilot.
Mm.
It all depends on the organizational capacity. There are organizations that have wanted to use the adaptive model, but recognize that they just didn't have the person power, which I think is probably one of the more common challenges with many organizations. I would say that probably realistically, somewhere between the second draft and the third draft would probably be pretty doable within a year. But also, it's also dependent on like what resources are available to really support this process. And if the organization is also able to get like capacity building assistance, that can really help expedite the process.
Thank you for that. And I can say on behalf of, as far as the Southern AIDS Coalition is concerned, in making decisions around funding for this one-year period, we do recognize that a 12-month grant cycle is a brief cycle when we're considering the exponential amount of work around adaptation. So we are also very much paying attention to what an organization that applies, what all they plan to do in that first year. So a very robust work plan that maybe doesn't conclude all of the steps outlined in today's webinar, but are very thoughtful and comprehensive, would still be strongly considered.
And also there was a second part to Kamisha's question, which is about, would it be acceptable if the organization only got to the assessment and decision phase? And I would say this is something that you negotiate with your funder. Because it's very common where the assessment process can end up taking much longer than anticipated, and usually it's the formative work that can really take a lot of time.
We got a couple of questions here, I think, regarding the types of interventions that we consider. So, Dr. Dacus, could you explain what you mean? I know you stated this in the presentation, but what you mean by evidence-based interventions for folks who may be asking?
Sure. So the acronym EBI is used quite a bit in public health, and so when I speak about evidence-based interventions at EBI, it's kind of like sort of like this dual speak happening. One is that there are a set of interventions that are supported by the CDC. That were formerly part of what was called the Diffusion of Evidence-Based Intervention Project, or DEBIs, that was in the early 2000s. And so it consists of a set of evidence-based interventions that have been proven effective. They've been rigorously tested with their priority populations, and they have been officially endorsed by the CDC. But there's also, EBI means like really evidence-based interventions that have an internal logic, a theoretical framework, and have been proven effective, but may not have been as rigorously developed as the ones by the CDC. So, for example, many clinical interventions are considered evidence-based because it's based on, studies that have proven that the theoretical framework, the effectiveness, and these will get the outcomes that are there. But strictly what I'm referring to more specifically here are the behaviorally based evidence-based interventions.
And for the purpose of this funding, and interventions that have been conducted in your communities, maybe with other organizations, as Esther Ross-Hines asked, as well as homegrown interventions, would be considered for funding under SAC's funding opportunity. Damaris, the question regarding, so the only funding opportunities would be through the 3 coordinating centers, but applying organizations can partner with medical providers. I see there's a question around hospitals. You would not have to partner with Emory Hospital to do this work, but you could only be funded through one of these 3 coordinating centers. But you can identify your own partners for actual implementation of your proposal. Marcus Hooks, your question, if your organization already has a program in place, would you need to work back through the model in this presentation to be a viable applicant? The short answer would be no to that. The purpose of these, of the overview in this presentation and the presentation prior, was really to provide a framework and roadmap for organizations, but organizations that don't necessarily utilize this specific framework will still be considered and still be viable candidates.
And there was a question that was before Marcus's from Vanessa.
Oh yes, I think I answered Vanessa. Let me know if I didn't, but homegrown intervention are can be considered for funding, yes. And that's why I want to make sure you all are clear that we are funding design and adaptation. So we are not seeking to fund just adaptation of existing EBIs, but the adaptation question is one that we hear quite a bit from organizations who aren't sure how to even begin that process. So we thought it was really important to have a space to provide a really strong roadmap around what adaptation looks like in adaptation of an EBI. But we definitely also encourage you to look at a process for design and piloting of homegrown interventions as well. Are there any additional questions? We have about 2 minutes left. Dr. Dacus, do you have any closing comments before we end the call?
Sure. I will say that, so, you know, as I mentioned before, so the adaptive model, I think, is really a great model to use. It provides, it's very prescriptive. It provides very clear guidelines, but it also is an involved process too. And that's something that I strongly encourage folks to keep in mind and consider. You know, so it's important. So that's part of the formative process, is considering whether, you know, we can actually start this process and kind of move progressively along the way. The other thing that I'll say is that I was really happy to hear that there was a question about like consideration of homegrown interventions, because, you know, there are lots of interventions that you folks have that are using in programs that really work, that we know, you know, can be supported, can be elevated, can really be cultivated and be developed into a place where they can actually be evaluated and probably become evidence-based interventions, especially, you know, given where you are in the South, and how it's important to have more interventions that are really grown in the South be made available to folks in the South. And then I guess my final comment would be that if you're considering any of the CDC endorsed evidence-based interventions, keep in mind that, you know, if it seems like it's a pretty good fit, adaptation may not necessarily need to happen. And this is why, at least even in the adaptive model, there is that phase B, where it's like you have a control group and you have a group that goes through that experiences the adapted intervention. So, you know, there are times where it may be that the intervention actually will work, and, you know, you may not need to do like a lot of adaptation, but maybe just some fine tuning around things, just to kind of make it a little more aligned with the organization and your setting.
Thank you so much for that.
Mm-hmm.
Thank you so much for your time today, everyone. We will make this presentation and other slides available on the Gilead Campus website in the coming days. We hope that you found this information useful and that can be applied to your work for this application and beyond. And thank you most of all for all of the important work that you're doing in the South and for your communities. And we are excited to partner with you in some capacity. So please also consider training opportunities and other opportunities that are listed on the Gilead Campus website as well. In any way that we can support you, we would like to do that. Thank you so much and have a great day.